Thank you, Brian, and thank you to my co-presenters and to Rethink for giving me this opportunity. How do you follow the innovations that have been spoken about? And as Brian said, how to use comedy with something. I'm trying to make this less dry and not as serious. If you go on to the next slide, I'll start to go through this. So I wanted to give you a little bit of an overview of where we started from about 4 years ago, and we looked at the current policy that had come out in 2016, and we recognised that we've had 30 years since the very first Health of the Nation suicide prevention missive came from the Department of Health as it was then, and 30 years later, we have a rate which is still around about 10 per 100,000, and we were scratching our heads and wondering why this was happening. And Pauline, if you move on to the next slide, please. And we looked at the developments that were going on across the country. We had Suicide First Aid, the Zero Suicide Alliance, we had men's clubs being developed, the really valuable expert by experience information about people's experiences, the post-vention work supporting the bereaved. And it was fantastic when the 5-year forward view brought out the 24/7 hospital liaison. All of these have made massive local differences. But we were still looking at the picture within our area in North East Lincolnshire, where NAViGO, which is NHS and social care work that we do there. We looked at the picture of what pressures we had in our service as a mental health provider. And we found that there were trends that seemed to be collated 12 to 18 months later around national data. And it was almost impossible for them not to be of influence when you sat next to somebody and tried to assess suicide risk, try to work with them. If you had it in your head, oh, by the way, it's 3 times more young men under 17 are going to kill themselves based on this data. It's so hard not to go there. And we looked at this is very valuable, giving us an idea of how things have been. But in this present time, it's that individual specific decision making that is going to be key. We need to know how someone has got to the point they have help sought. And one of the things we did was we opened our doors. If you go to the next slide, please. Thank you, Paulina. We had 240 to 340 crisis referrals per month. We've opened our doors well before the 24/7 policy came out, and we said you don't need a referral, you can just turn up. We were concerned about staff workload, about retention of staff, the saturation of services, but we felt this was the only way to ensure that if people needed to help seek, they could. And we saw a range of presentations, a range of life event drivers leading to suicidal ideation and behaviour. Next slide, please, Paulina. Thank you. And we also recognised that we couldn't do this alone, that we needed to work with our local stakeholders. We needed to ensure the support was bespoke, the treatments targeted what had caused this help seeking, what had driven the suicide risk. And 4 years later, we are seeing 2 to 3 times as many people with suicidality presentations compared to other NHS sites. And again, this is data from 18 months ago, so it tells us that we have the lowest rate in our region, even though we are seeing up to 3 times as many people. The fascinating finding, the one that really hit us as important, was that 80% of the people coming through our doors, these up to 340 a month, saying, I'm thinking of killing myself, I'm going to kill myself, I've just been brought in by my family or my friends, or I've come via the hospital liaison. 80% of them were there because of social care needs, life stresses. These had led to low-level anxiety and depression, but that wasn't the primary reason for the suicidality. And we're mental health professionals, we treat mental health pathology. And we realised that we could treat the anxiety and the depression, even though it's low level, but we aren't actually targeting the very reason somebody has started to develop suicidal thinking in the first place. If you could go into the next slide, please, Paulina. So this is the data as of last month. over 10,000 suicide triages have been done in the last 4 years, since April 2018. The earlier we intervene, the more likely we are to prevent any of those cases becoming the 1% where there is life-threatening behaviour, there is a risk of suicide that we have to then utilise our various systems of care in crisis and in acute services. I'll explain a bit more if you go to the next slide, please. And here's some data from something we looked at when we got to around 6,000 triages. And we found that 21% of the 6,000 had a diagnosable mental health condition. We found that there was mild to moderate anxiety and depression in about a quarter, which wasn't at a diagnostic level, and it was in almost all cases triggered by a life event. And I'll come on to what those life events are. We had individuals who were so distressed they were using self-harm to just cope with the emotions. And we had about 1 in 6, roughly 1 in 7, where we had severe anxiety and depression and intrusive thoughts. And this was mental health diagnostic level problems that can be treated with the treatments that we have and the therapies we have. And the 1% was a very consistent figure where we had life-threatening risk. And that's when we use something called the Collaborative Assessment and Management for Suicidality. It's American, which they don't know about child and adolescent mental health services there, folks. So that's why they called it CAMS, which is always going to be something I'm going to have to explain whenever I talk about it. And that was initiated for those cases. Next slide, please, Paulina. And these are some of the primary reasons. So the highest bar there is for a quarter, and that's mild to moderate anxiety and depression, and that is secondary to aspects such as homelessness, losing your job, relationship problems, parental alienation, the list goes on. We can prescribe, we can provide therapy, we can moderate mild to moderate anxiety, we can reduce it, and depression. We are still going to have that initial trigger problem. Self-harm and emotional dysregulation without not in the context of a diagnosis. Then we have the first diagnostic group, severe anxiety and depression with intrusive thoughts. Then you have relationship breakdowns. We also had a core where people engaged, and during the assessment their suicidal thinking wasn't observed. They were supported, the emotional and practical support provided very, very quickly relieved that. Then we have substance misuse, and we have physical health problems, bereavement. Then another diagnostic group for people with psychosis or relapse of their and most of these diagnosed individuals were known to services. So it was really a relapse of their mental health. Then we had social isolation, housing issues, and parental alienation, involvement of children's services, removal of children, and domestic abuse. And one of the things we're very wary of is that we have, I think, probably the largest real-time case series data set of people presenting with suicide risk in the NHS. I haven't heard, I'm happy to be corrected, but it's 10,000 strong. And we recognise that by having that information at a local level, absolutely in the here and now, allows us to look at how any of these social care needs alter, and they did over COVID. We know our links with local refuges and for domestic violence were particularly under pressure during COVID. Next slide, please, Paulina. So the 6-month follow-up data has shown us that people accessed our single point of access. We set up something called Safe Space where people could come along and have emotional support, practical support, look at problem-solving solutions. Crisis and liaison were available 24/7, and then some people even had some therapy. But by 6 months' time, 90% had been discharged from all NAViGO services. Next slide, please, Pauline. And that's it, thank you. And this is the kind of thing we did within our triage process. If you just press it once more, please, Paulina, something will come up. So this was a study from America, and this is about crisis response planning. And here's somebody whose warning signs were pacing, feeling irritable, thinking, I'll never get better. And they helped we collaborated in developing this list of things they could do. So in this case, go for a walk for 10 minutes. Why is it valuable? Watch your episodes of Friends. Sorry, folks, I don't get Friends, and I'm going to get lots of questions about that, but a lot of you do. Play with my dog. My daughter gets Friends, and she tells me off, Dad, you clearly are too old. So think about my kids, the vacation we had in Florida, Christmas Day, call, text my mom, my friend Jennifer, call Dr. So-and-so. So this would be equivalent of our crisis service, and using talk lines as we do with the Samaritans, and go to hospital, and they would say that would be for us, go to the crisis team, the door will be open, and then the emergency one at the end. And once you put this in place, it was very clear that you allowed individuals to break that chain as they became more and more overwhelmed. Next slide, please, Paulina. Thank you. And here's one thing I wanted to just clarify. This is what we recognized was the key here. We talk about depression, we talk about trauma, relationship, all these things I've mentioned, bad grades, unemployment, homelessness, parental alienation, incarceration. Those are not the direct drivers of suicide. If you press the once more, please, Pauline. Thank you. The direct drivers, a lot of people struggle with any of these indirect drivers, but not everyone who does wants to kill themselves. The question is, how are you seeing the indirect driver? Whatever it is, a diagnosis, a life event, a social care pressure, unemployment, anything that makes you feel like suicide is an option or the only option for dealing with it. And that's the key question. And that's what we do in triage. And the example I give is that two individuals can lose their jobs. And one of them may see it as an attack on their ability to pay their mortgage, pay bills, pay for their children's school dinners, compare themselves to their friends and siblings, not be able to talk to people, feel ashamed, and might choose suicide as an option because this is so overwhelming. It's such an attack on the self. The other person may well see it as, I'm going to go get a job, unskilled labour, I'm just going to make a bit of money, I'm going to just try and keep my head down and keep going. They may have anxiety, they may have depression, but if I treat that anxiety and depression, the initial life event is still a problem. So that's why direct drivers are the individuals, I suppose, appraisal on the reason why suicide is an option. Next slide, please, Paulina. So what does it all mean? Well, we think an open access service maximises the opportunity for anyone to help seek. And this is scary, but it can be done. The earlier we intervene, we stop the trajectory. That's the key. We mustn't have, if everyone's hitting our crisis services, we're going to struggle. The mental health treatment can reduce distress, but doesn't resolve the risk if 4 out of 5 of the cases are to do with life events and social care needs. And it's that personal belief that's key. And that's the bit that allows you to recognise what the drivers are and how you can deal with them. Next page. Thank you. And we have evidence-based trainings. We've heard about them today. Some wonderful stuff going on at CNWL. We have post-mention assists, suicide first aid, zero suicide. We've no evidence-based treatments for suicide prevention. The CAMS, Swift et al., the only academic bit I'll mention, folks, meta-analysis, independent one, guideline standard evidence from the clinical trials. CAMS reduces suicidality, hopelessness, general distress, and it's acceptable. It's widely recommended in the US. Please, we need NICE to evaluate it. Next slide, please. And ultimately, it's that, as I've said, I'm going to keep saying it, it's the individual meaning of threat to self that leads to direct drivers of suicide. The earlier we intervene, the more we link in with local innovations, national innovations. We have some brilliant ones with Rethink in North East Lincolnshire, with men's clubs. All of this allows us to have a two-way process. We need that process so that we can deal with aspects where something like CAMS can intervene, and we can also utilise social care, emotional, practical support, all of that work around planning that we've talked about. Only 20% of the people we see require mental health treatment. We need things for suicidality as well. If we continue to apply mental health treatments for these problems, the rate that we've had since 1992 will continue. Next page, please. So finally, moving forward, frontline staff, we need a guideline standard treatment. We need to understand suicide as a viable option for the individual when it is a threat to their self-image based on their belief of a catastrophic future. We have to connect with our stakeholders. We cannot do this without having that connectivity in our localities. And we can treat mental health symptoms, but that's not always the be-all and end-all for suicide prevention. Final slide, Brian will be relieved to know. Some of the developments we've done, the application of CAMS, we have started offering the training for CAMS, the resources and the consultation around the NSTM, which is now award-winning, and that's everything. Thank you very much for your time.